Today, I have the great pleasure to host Doug Paul on our iCAAD channels. A very warm welcome, Doug, today.
Thank you very much for having me all the way from across the pond. I'm really excited to have this conversation. Thanks.
Thank you, Doug. So just a word about Doug from America. Doug has been a clinician for the last 15 plus years in acting in different ways, from being a clinician into being a clinical director in many different treatment facilities. Today he is a private practitioner. One of the field of interest of Doug is craving. Doug, first question that comes to my mind, in your trajectory at some point you became preoccupied, fascinated, interested into the craving phenomena. From a personal perspective, why that?
Wow. I think that really gets down to kind of the basic question of substance use disorders, as we call them over in the US, and that is this phenomenon of craving. As a person myself in long-term recovery, it was something that I struggled with early on. I didn't really know that, though. It wasn't until later on in my own recovery process when I looked back at my life and was able to say, wow, this is something that I'm really having a difficult time with. Was I able to kind of put words to and maybe put a label on my experience of having cravings and trying in some ways in a vain attempt to manage those cravings?
I just realized something, that craving is a tricky word because it's very well known as a word. It's almost a lay people terminology. I crave chocolate, I crave that, I crave this. But I realized that well, I've seen that in university research, but we take it for granted. So I think it's a good time to just trying to conceptualize that, especially with the different trajectory of the addiction surge with prescription drugs, pills, and different things where there's a lot of craving here. And also the DSM-5 has now integrated the craving as one of the domain and dimension that characterize substance use disorder, or what we used to call addiction. So let's try to get into the conceptualization. What is craving? In your 3 words, there's multifaceted craving and management. Let's start with the middle word here. What do we understand by craving?
The first statement that I want to make about that is that we don't understand a whole lot. And actually my source material, there is a book written by American Society of Addiction Medicine's president, Paul Early, and it was written several years ago. And I don't know that there has been a lot more research done on this. I know that we can always do more to kind of narrow our definitions of certain things, but using my source material, the chapter out of this one book that I'm referencing mentions 4 separate craving types.
Right. So 2 things here. If I hear you properly, there's a deficit of profound knowledge of what it is, in maybe a deficit of research, which is maybe concerning. There is an acknowledgement that craving exists. There are 4 types, and maybe we'll get into that in 5 seconds together, just to start to unveil a little bit the structure of what is craving. But there's also something you just mentioned. It's also a perceived phenomena. So we got the objective description of what could be craving from a scientific perspective, but there's also something to take into account, that craving is deeply, painfully experienced from within with a patient, right?
Exactly. And when we hear these broad statements like, well, I really like chocolate, I crave chocolate. This is one of the reasons why I don't have a bowl full of Hershey's Kisses in my office, because I'd just be surrounded by little silver wrappers, because I just love chocolate so much. And at times I do find myself craving chocolate. That is differentiated from the experience of the sufferers of substance use disorder. That is not what they're talking about. What they're talking about is an intense, obsessional, emotional experience where it's like I like chocolate, but it's more like I have to have the chocolate. My life depends on having the chocolate. And so it really kind of explodes this concept that in public in popular culture of the word craving, because their experience is so different from the way that everybody else uses that word.
Well, that's very important, because when we see those words being used in the common world, there's a tendency to minimize what it is. What you said, I think, is very important. It's a near-death experience when we have a craving. My life depends on it. So if I don't have it, I may well die. Now, that's perceived, may not be true from a clinical or biological perspective, but nevertheless, when we start to think that we may well die if we don't get something, it's quite convincing, and we're quite persistent into getting it, right?
Absolutely. To the gates of insanity and death, as some of the literature, the recovery literature references. And that actually brings me to an important point, and that is in the recovery literature, the kind of the source material of the recovery movement, of which I am a part, it mentions the word craving in some of that literature. And when it mentions that, it is specifically talking about just one particular type of craving of the 4 types.
So let's name the 4 types. How do you name them, and then how do they differentiate or contrast?
Sure. So the very first type that's mentioned in Dr. Early's book is the type of craving that is, I think most people can relate to. It's the idea that, let's take Hershey's Kisses, for example. I love chocolate. And when I have one little Hershey's Kiss, I want another one. That's the first type of craving. So as soon as I begin eating those Hershey's Kisses, I have a very difficult time getting stopped eating those Hershey's Kisses. So it's reinforced use, conceptually the easiest one to understand. The second type of craving is a more clinically significant craving, because the first one happens before the individual seeking treatment actually starts seeking treatment. And that craving ends when they enter into abstinence or enter into a medication-assisted program or something like that, where their cravings are being treated appropriately. So the second type of craving actually happens in a treatment setting. And it's brought on by emotional experiences, by physiologic experiences, and it's called overt interoceptive. So overt, I can label it. I can tell you that I am in this moment experiencing a craving. Interoceptive, because it's triggered by either an emotional response or a physiologic response, usually a combination of both of those. The third type of craving is called covert craving, clearly a clinically significant style of craving, because covert indicates that I'm not even aware of it. It's not even on my radar. I can't label it. I can't acknowledge it. And when someone comes to me and says, hey, it seems like you're upset or disrupted, or are you craving? I'm absolutely going to say, nope, I'm not craving. That's not what's happening right now. And then the last one, which is kind of it runs an undercurrent. So underneath the other 3 types of craving, as they run their course through a typical treatment or early recovery episode, this type of craving is always an undercurrent. And it's really based on our ability to look out into the environment to decide what's good for survival versus what's not good for survival. So learning, so a real Pavlovian reaction.
So let me pick up on actually the second one you named. Listening to you, because I'm French, and so I'm quite attuned with the French culture and things that have been done in France. In the early 70s, a French doctor called Olivier Stein was one of the first in France to address opiates addiction. He developed an embryonic hospital, treatment center, whatever you would call, no concept of American Minnesota there. He did it his way. But he said something in a book called There Is No Happy Druggies. That was a lay people book, but there's no happy junkies or druggies, whatever. And he said something. The main thing that we don't understand is that any drug addict has a fear of the fear of craving. The fear of craving. And that leads to relapse. So we're in 1972 now.
Wow. The year I was born.
Well, and I'm grateful to that guy because I remember I read his book. I was 15 years old, already hooked with alcohol and coke, and I was interested, but not thinking that I had any problem, right? But I remember that sentence all of a sudden, thanks to what you just shared with me. And there's something here with the anticipation of the anticipation of the anticipation is triggering something that is on the make that leads eventually to, wow, I'm going to use.
Yeah. I'm hearing really a kind of a combination of two types of craving that we just talked about. I want to talk about that undercurrent. So this classical conditioning idea, and that is that maybe as opioid use disorder is concerned, but it's also true with benzodiazepine and alcohol use disorder. And again, I'm using DSM-5 terminology. But with these types of experiences, when I am taking the substance and then I abruptly stop, I enter into withdrawal. Yeah. And that's not a pleasant experience. It's pretty awful, and in some cases can even be life-threatening. So what happens is I begin to learn. After doing that a couple of times, I begin to learn, like, oh, that was awful. I don't want to do that again. How do I avoid that? So my body starts providing me information that even when the slightest beginning of a withdrawal syndrome, starts, I immediately recognize it. I am triggered by it because I don't want it to slide any deeper into a full-blown withdrawal episode where I start to feel really awful and may even require, medical intervention for assistance. So at that point, my brain releases chemicals and it says, okay, now it's okay for you to go and start seeking out this substance. Where you may have had some kind of commitment to abstinence. No, I'm going to stop. I'm really going to try hard this time. Once those chemicals are released in the brain, it's like a free-for-all. It gives me permission to go out and seek substance use.
Almost like if the fear of the pain is shutting down any self-regulation, cognition, and takes over all the process, which maybe explains something. I remember reading a paper from a guy called Tiffany, who is from the School of Automaticity in psychology. You may remember those things. So he said basically a craving. I don't know why he was preoccupied with craving. He wrote a couple of papers in the late 90s, I think. And I remember when I read his papers, he said, craving is, as you described, so massively attuned to fear, pain, and profound emotion that it becomes an automatic process. So when we have an automatic process, first of all, how do we arrest it? Because it's automatic. And the assumption from Barge and Tiffany and others that automaticity is such a driving force in the mind and the brain functioning that forget about trying to rein it with cognitions, explicit cognition, because it's implicit. So he says basically, how do you stop that? Second, the only ending of a craving is using, with a certain kind of psychological logic here, which is scary. Because these are very strong forces, and if we want to develop recovery, cognitive processes are interesting, emotional regulation is interesting, but craving management is equally central.
Absolutely. I mean, I think they're all tied in together. I mean, I think about this idea. So for myself, I struggled with cravings both during active addiction and then during my treatment episode, but I didn't really know it in my treatment episode. It wasn't until later that I realized that was what was going on. But I remember in the final few months, right before I, made that very important phone call to my family and said, "Hey, can you help? I need some help here." And they were obviously, "Yes, we can help. We would be glad to. We've been waiting for this phone call for years." I remember having cravings and the way to make them go away was to use, and it worked really, really well. As soon as I had a craving, I would use, it would go away, and then it would come back, and then I would use and it would go away. And here's the cycle, right? I'm on the bicycle. I'm going around and around and around. I think it's so important in the treatment setting, in the clinical setting, when the client has that first craving episode, without substance use available. They're going to have to walk through that without being able to kind of relieve the craving with their one tool that they know works. If I have a craving and I use, it goes away. But now I'm having a craving and I don't have that substance available to me, or any other combination of other substances that I would use in order to make the craving for one substance go away, and to assist them, to walk with them through that first craving episode, so that they get to the learning component of, okay, I had a craving and I watched as it went through its cycle, and within 45, maybe 60 minutes at the maximum, the craving subsided. I found that I could use techniques to help me with that, distraction techniques. Take a cold or a hot bath, grab a piece of ice and kind of grip it in your fist, take a rubber band and snap it against, all of these kind of DBT, emotion regulation techniques that we use, to distract myself, to take my brain and kind of, okay, here I am, I'm focused on the craving. Can I go off over on this direction so I can get my brain not so much focused on the craving, and then just observe as it vanishes.
So would you say that the resolution of the craving, or the stopping of the craving without using, as you said rightly, we need to deflect. And you mentioned some techniques that are actually connected to the body rather than the mind, right? So the cube of ice, or the rubber band, the DBT thing, yeah. So would you say that craving is to be managed from the body first?
That's an interesting one. I might actually say that it's an individualized process, right? What works for one individual may not work for another individual. So, the rubber band snapping against the wrist, or the ice, either of those might work for one person, not so much for another. So it depends on the individual. Maybe one individual has some cognitive skills that they've been able to utilize to really help them work through this, while another person might really need some kind of behavioral containment to really help them. And that's a very individualized process.
So what I take from what you said here is it's individualized, but there's another thing. That craving, management of the craving, first of all, cannot necessarily come from within. It needs to be helped by someone who is walking the walk alongside the craving loved one, or the patient, or whoever is experiencing the craving. And sadly enough, I've heard so many times, oh, you're just craving, this is going to pass, just be patient. It's going to be like that for another 4 weeks or another whatever. And people are just panting in their process of recovery, and they're going to leave treatment and they're going to be back into the wild. And the clinician is going, this is going to pass. And I just have a moment of anger right now. My stuff. And that's not fair, right?
It is a little dismissive, isn't it? To say, look, just sit there, it'll go away. It's a bit dismissive, and instead of like, oh, well, take my hand, let's go take a walk. Let's talk about what's going on. Let's talk about the things that preceded the craving episode. That's an important component too. What were the feelings that happened right before you first realized, oh my gosh, I'm having this massive craving right now? Who were you talking to? What were you talking about? Where were you? What were the sensations inside your body? And almost invariably, when we start talking about those sensations, about the interoceptive experience of physiologic response with craving, we begin to see that these are predictable. I can actually begin to make a list of physiologic response that I had, and they are typically the same feelings that I would have right before I would use before. So frustration, kind of all of the dysphoric, emotions, but also sweaty palms, racing pulse, dry mouth, a lot of the sensations or symptoms that would occur right before I would typically use substances. I can begin to catalog those for future reference, that when I experience them in the future, I can begin to anticipate craving. That's a really useful skill.
Yeah. And that's so important, that the craving can be managed outside, as in before the craving. So we need to backtrack that, which is something that it's prevention. Huh? It's just a preventive management. I remember, the old timers in AA used to say, "Hold, hungry, angry, lonely, tired," as intuitively a way to address that. Now, I think we owe to our patients to try to bring a bit of science there, to try to make it more systematic, probably. But then let's go with let's track that. So flag identification, precursor of the craving, that's precocious, and that's prevention management. Now, if we got it too late, then we have probably to deflect with the body, right? To try to get the body somewhere else, which is the whatever ice cube it is, or whatever the strategy. Now, let's get into the other thing that you mentioned that I think is very important: the covert, the non-obvious part of the craving, the one you described as in slightly, undetectable kind of thing, and then at some point there's someone saying, just getting angry now. It's not about anger; it's maybe about a craving, thing like that. Because these are the ones that are going to kill you eventually, right?
And this is the type of craving that people leave treatment over. Most of the time, most people, they have, at least in the early stages of treatment episodes, typically they have a lot of commitment. And they're saying to themselves, look, I've experienced these consequences. I don't want to continue to experience these consequences, so I'm willing to go through a little bit of discomfort in the beginning. And recognizing to themselves that discomfort is just part of this process. It's same as in any healing process. If I break my arm, I need to walk through that discomfort of having a broken arm, and I'm willing to do that. But the covert craving is the one that people leave treatment over because it's not even on their radar. They're not aware of it. It's, in fact, not a craving to them. Subjectively to them, it's not a craving. Although all of their treatment peers around them are saying to themselves, oh, boy, it looks like Jim over there is really getting ready to leave treatment. He must be craving badly. But to the individual, they're like, no. And so when they start hearing their peers or maybe their treatment provider saying like, hey, are you craving? After you've been asked that question 3 or 4 or 16 times, it's like, you know what? I'm starting to get a little annoyed right now. And so there's this connection between irritability and covert craving. Irritability is a hallmark, and this is how irritability works. Stay away from me. Don't talk to me. Just let me be by myself. And whether they're saying that or their body language is putting that off, people pick up on it. And so they leave him alone. I'm not going to mess with him. He seems really irritable right now. So they leave him alone, and that's exactly where the disease wants them. It wants them alone and not aware of what's going on or self-attuned to what's going on in their body. And that's when the craving can kind of have a breakthrough and go, okay, now it's time to leave treatment. Everybody in here is upsetting you anyway, so they keep asking the same 5 questions over again. So now it's time to go.
So, would you say that craving has a core of stable process, irrespectively of what addiction we're discussing, or do we have variances depending on the substance or the process? Addiction at stake, so that cravings manifest significantly differently, or even is a different process?
Do you mean by substance class?
Well, yes, by substance class, and including gambling or behavioral addiction, sex, or whatever. Now, obviously, there is a difference in physiological aspect of that, but in terms of the 4 categories of craving, the way you described, do we find them in a kind of similar way, no matter what the addiction is about?
That's a great question, and not an area that I have done a lot of research in. So I don't know that I would be able to answer that question effectively as far as looking at the different behavioral components. Now, when we speak about substance class, we do see some similarities between depressants, stimulants, analgesics. We definitely see similarities there, and so there are certain techniques where that maybe might work in the opioid use population versus the alcohol use disorder population. So definitely some similarities there.
Okay. So just to sum it all up, do we have any idea how much the craving is playing a role into the process of chronic relapses compared to wrong behavioral choice or an absence of explicit engagement to recovery? I mean, what's the part of the implicit craving compared to the explicit lack of engagement into ways and means of recovery? I suppose what I'm trying to ask is how much there is some sort of doom associated to the craving, nevertheless the best intention in the world to get into recovery, if it makes sense.
No, I think I understand where you're going, Christophe. I saw a pharmacist talk at a conference a couple of years ago in this particular university, just outside Atlanta, Georgia, was doing research on measuring dopamine release for each substance class, and it was just amazing, an amazing presentation. And I came away from that presentation even more curious than I was before about this phenomenon that we're talking about of craving. And what I really think is the more I know, the less I know. So the more I learn about brain chemistry, the less I think I know. What I think is happening is that brain chemistry and all the behaviors that we have are really just an outward representation of what's going on inside our brains. And with our substance use population, we have dramatic, profound changes, some of them permanent, in brain functioning. Most of them, thank goodness, are not permanent, and the brain is incredibly elastic and can repair itself. And so a lot of those pathways are not permanent, and so they can be repaired, but it takes time. So, is it a behavioral concern, or is it something that can be addressed by pharmacology? I think it has to be both. We have to provide some kind of containment, some type of behavioral container for the problem behaviors that are a result of altered brain chemistry, while we treat underlying psychiatric disorders, depression, anxiety, bipolar, and that when we do that effectively, craving is an opportunity to learn. As I observe myself, I can look down at my shoes and I can tell you, are they pointing towards the door or are they pointing towards the middle of the room? If they're pointing towards the door, that's where I'm headed. I can begin to kind of be a fly on the inside of my own head and watch as my brain delivers me new and different types of signals that I wasn't aware of before.
I really like that vision you're proposing right now, and the opportunity from the craving to learn something about ourselves and the internal process. Addiction treatment has something to do with working the internal process and the internal models, absolutely. Thank you so much, Doug.